For your patients with hard-to-control hypertension, are you struggling to achieve blood pressure goals despite treating with at least 2 antihypertensive medications? Uncontrolled hypertension increases the risk of death and stroke for many patients. Not all hypertension is the same. For many of these patients, you may want to consider a different pathway. Aldosterone may be to blame. Visit blamealdo.com to learn more.
Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated CardioNerds everywhere are working hard to fight this global epidemic. These are their stories.
Hey, CardioNerds. We're very excited to dive into the electrifying world of anti-arrhythmic drugs in the management of atrial fibrillation and atrial flutter as part of our atrial fibrillation series. This is Kelly Arps, and I am joined by series co-chair Dr. Colin Blumenthal, episode lead Dr. Natalie Marrero, and very special guest and absolute expert in this field, Dr. Andrew Epstein from the University of Pennsylvania. First, some introductions. Dr. Natalie Marrero completed medical school at Johns Hopkins University School of Medicine and is now a medicine resident at the University of Miami. Natalie, thank you very much for planning this discussion as the episode lead, and welcome to your first CardioNerds podcast recording.
Hi, Kelly. Thank you for that wonderful introduction. It's a pleasure to be here.
Okay, I have the great privilege of introducing Dr. Andrew Epstein. Dr. Epstein obtained his medical degree from the University of Rochester School of Medicine and Dentistry in New York. He went on to complete his internal medicine residency at Barnes Hospital at Washington University in St. Louis and his cardiology fellowship at the University of Alabama, where he also served as chief fellow. He is currently one of our electrophysiology faculty at the University of Pennsylvania Perelman School of Medicine and is the chief of cardiology at the Philadelphia VA. He has published extensively within the field of arrhythmia, including several pivotal trials in the field, and serves as a professor clinician educator of medicine. I personally am very excited for this episode because I have heard him speak many times on anti-arrhythmic drugs, and he is a phenomenal speaker. Dr. Epstein, thank you for joining us.
Thank you very much, Colin. I'm delighted to be here.
Okay, let's start with a case from the CardioNerds Arrhythmia Clinic, a very busy clinic. Mr. Phibb is a 58-year-old male with a past medical history of hypertension and diabetes. Presented to his PCP 2 months ago with intermittent palpitations that happen infrequently but can last for hours at a time. ECG at his PCP office was unremarkable. His PCP ordered an event monitor, which came back with intermittent episodes of atrial fibrillation, with one episode lasting 16 hours. Atrial fibrillation is a new diagnosis for Mr. Phibb, and his PCP started him appropriately on apixaban and referred him to our clinic. Just for a brief plug, if you are interested in learning more about anticoagulation and the use of anticoagulation, I would definitely look at some of our previous episodes. There are a lot of pearls there. In the clinic, he mentions that his friend has atrial fibrillation as well and takes a pill at home whenever he feels palpitations. He thinks it's called Fleca something. He has never had surgery before, and he, quote, doesn't like the idea of you putting tubes into his heart. So, Dr. Epstein, I feel like everyone these days focuses heavily on ablation, but there are many other tools in the toolbox to treat atrial fibrillation. Can you tell us about the indications for antiarrhythmic medication for the treatment of atrial fibrillation? And sort of a second and third part to this, do you think a class 1C antiarrhythmic agent like Fleca something? Yeah, just kidding. Flecainide or propafenone would be a good option for Mr. Phibb? How do these medications work?
Well, there's a lot in your question, Colin. I'd like to begin by emphasizing that this argument about should my patient take drugs or should they have ablation is really a moot point. And I want to bring up 2 studies to show that this is really a marriage that we have of 2 different modes of therapy for atrial fibrillation. One doesn't supersede the other. They have to work together. There was a trial called EAST-AF-NET 4, which looked at the outcomes of patients with AF that had been present for less than a year to see if they did better with a rhythm control strategy or conventional care in the community. And it turned out that with a rhythm control strategy and attempt to maintain sinus rhythm, people actually lived longer and did better. In fact, in this trial, though, at the initial entry, only 8% of people underwent ablation, and at 2 years, the number was 19.4%. So this was a trial that showed excellent outcomes and improved outcomes with rhythm control, but using drugs rather than ablation. And then a study from Dr. Sanjeev Saxena, who is one of the past presidents, actually, of HRS, looked at the usage of drugs peri-ablation. And in fact, in this study that comprised over 23,000 patients, the authors found that 16% of these individuals underwent more than one ablation. At the time of initial ablation, 62%, I think, were taking drugs. And when you got to a fourth ablation, it was 92%. Importantly, people didn't necessarily stop drugs after ablation either. And after the first one, 32% stopped, but the others remained on it. And in fact, after greater than one ablation, I guess it was 14% stopped drugs. So drugs and ablation go together. That's number one. Number two, you asked about the utility of class 1C drug for the patient that you presented. The 1C drugs are very effective and well-tolerated drugs. The caveat is the risk of ischemia, and I think we'll talk about that a little bit later. The second point has to do with the use of a 1C agent versus something else for the patient who was presented. All of the guidelines, whether it be the ACC, AHA, the ESC, or wherever, support the use of antiarrhythmics with either a class 1 or usually a 2A indication. I feel very strongly that amiodarone should not be the first line of drug therapy for patients who are most of the time otherwise well. The problem with amiodarone, of course, is the toxicity that comes with it. And once somebody does have a toxic reaction, the half-life of amiodarone is 107 days. The volume of distribution is 5,000 liters, and it takes an age to get the drug out of our system. So the toxicities with the lungs, the thyroid, the liver, and so forth are real, and it's a drug to avoid and use as a second-line therapy. For somebody who doesn't have ischemia, class 1C drug is great. And for this gentleman who, quote, talks about a fleck of something and doesn't like the idea of tubes, to have a drug that's available that he doesn't have to take on a daily basis would be very nice for him. The way pill in a pocket works is that you do not take an antiarrhythmic drug every day, but when you feel palpitations that are known to be atrial fibrillation, you can take a single dose and hope that the AF resolves. The doses of flecainide and propafenone for this are either 300 milligrams or 600 milligrams as an immediate release formulation. The conversion rate is well over 50% after a couple of hours. Who would you use a drug like this for? A patient of mine that I recall very well was a traveling nurse and did missionary work in South America. And rather than taking a drug every day, he had pill-in-the-pocket flecainide. And if he got atrial fib when he was in the wilds, he would take his dose and usually convert. This is not for somebody who has paroxysmal atrial fib 3 times a week, but somebody who has it once every several months, or for this gentleman, it was once every 9 months or so. It worked perfectly.
That is all just phenomenal information. And then I guess the 2 follow-up questions I would have to that is, one, what about patients who do have symptoms more frequently, paroxysmal atrial fibrillation? Could they take it continuously? And then sort of talking more broadly about these 1C agents, how do these work? What is the mechanism of action for them?
Well, all of the 1C drugs, like the other class 1 drugs, are sodium channel blockers. The 1Cs are very potent sodium channel blockers, so they prolong depolarization. Although the QT interval reflecting repolarization is lengthened, it's not because repolarization is extended, but rather because depolarization is prolonged. So from the end of the QRS to the end of the T wave, the so-called JT interval is not prolonged with these drugs. They are very effective to both terminate atrial fib as well as prevent their occurrence. I'm sure everyone is aware of the pivotal trial called CAST, for the cardiac arrhythmia suppression trial, which most of us know. An important recognition there was that 1C drugs have the potential for increasing mortality in patients with coronary disease and myocardial infarction. It is important to recognize that sub-studies from CAST examined the role of ischemia in this mortality signal. And in fact, there are 2 papers, one from Toshio Akiyama and the other from Jeff Anderson, that showed that the people who died in CAST were ones who had non-Q wave infarction and or ongoing angina, reflecting ischemia. And in fact, if ischemia is excluded in a patient who is at risk for that, that would be people who are smokers and obviously males in this country. The drugs are very well tolerated and they can be taken for a long time. They do not have organ toxicity and they're well tolerated.
Dr. Epstein, it sounds like this class of medications has a great balance of safety and efficacy. Also, I love that the pill-in-the-pocket approach seems that it can significantly reduce ER visits and hospitalizations while helping patients feel much better and limiting their pill burden. I have heard about the risk of fast atrial flutters with these medications. Given that we just learned about how these medications work, how does this contribute to the effects on atrial flutter, and what are prescribing practices to help prevent these adverse events?
That's a great question, and in fact, a very important one also. Because as I said, these drugs slow depolarization. They markedly slow flutter circuits. So for classic CTI-dependent flutter, it is usually at a rate of around 300 beats per minute. These drugs can slow the flutter rate to like 240 beats per minute. At 300 beats a minute, AV conduction is 2-to-1, giving a ventricular response of 150 beats per minute. But at 240 beats per minute for a flutter rate, actually 1-to-1 conduction can occur to the ventricle, and it's a supraventricular proarrhythmia. And that can be associated with hemodynamic embarrassment and is a real problem. So when these drugs are used, a beta blocker should always be used to block the AV node to some degree to prevent 1-to-1 conduction if a flutter occurs on the 1C drugs. And this prevents 1-to-1 conduction. Early in my career, I always used a beta blocker with flecainide, but not with propafenone, because propafenone has beta blocker effects itself. But in fact, the beta blocker effects of propafenone are relatively small, and 1-to-1 flutter can occur even with that drug. So whether it be flecainide or propafenone, a beta blocker should be used.
Absolutely. And, I'll say that this is something that I've started counseling my patients about specifically just to protect them from, any other physician or team trying to make changes to that combined regimen. The last thing that you want to do is treat a minimally symptomatic patient with flecainide and then create a severely symptomatic arrhythmia. You were speaking about the CAST trial earlier, and I wanted to dig in just a little bit more. When you have a patient who you're treating with flecainide or propafenone who may have some risk factors for coronary artery disease, how frequently are you screening them for ischemia? And can you go into a little bit more detail about exactly what threshold you would use to stop this agent?
Yeah, that's a good question. In terms of starting the drug, I always get a stress test if somebody's at risk for coronary disease, and that'll be a male over 40 and smokers. In terms of how frequently to assess ischemia during treatment with the drug, I think at least at a year, every year, year and a half. 2 years is probably too long. There's not any guidance on it, but it just sort of makes sense that coronary disease can progress after a year. So every year, year and a half, I do get a stress test.
On that note, what do you make about calcium scores? We have a lot of patients who have had a CT scan for one reason or another, and for instance, may find that their calcium score is in the upper percentile for their ACE, and they may find that their calcium score is in the upper percentile for their age, race, and gender. How much do you factor that into a decision about the safety of Class 1C agents?
That's a real complex question. First of all, in terms of the presence of coronary disease and atherosclerosis, we know back going to the Korean War, actually, that 18-year-olds who were killed already had yellow plaque in their aortas. So for the American diet, atherosclerosis starts early. That being said, many people are going to have positive calcium scores, but have not necessarily obstruction and certainly not necessarily ischemia. So the functional testing for ischemia is what's important. And CAST didn't screen with calcium scoring either. Ischemia is the big worry, and that's what we should be screening for. In addition to screening for ischemia, there's some other evidence that is very enlightening on the risks of using 1Cs in people with coronary disease. In the approval process for the long-acting propafenone, there were 2 trials that were done. One was called RAFT, which stood for the Rhythmal Atrial Fibrillation Trial, which was done in the United States, and patients with coronary disease were excluded. And a companion trial was done in Europe called ERAFT, for the European Rhythmal Atrial Fibrillation Trial. The European trial was important because it did not exclude patients with coronary disease, but to get into the trial for atrial fibrillation, if you had coronary disease, you had to be a year post-infarction, have a normal left ventricle, and have a negative stress test. And in that trial, there was no proarrhythmia or deaths related to a proarrhythmic effect of propafenone.
Thank you for highlighting such an important consideration, Dr. Epstein. It really shows how nuanced this information can be compared to some of the blanket statements you learn or even in the guidelines, which is why management by a specialist can be so important and why individualizing our clinical decisions is so important. Dr. Epstein, what about the other side effects and considerations of 1C agents? What are common side effects to look out for and drug-drug interactions we should know about?
In fact, there's really not much. Certainly because of the membrane actions of these drugs, they're negative inotropes. And so people with left ventricular dysfunction are at risk for precipitating heart failure. So most of us don't use these drugs in patients with cardiomyopathies. The effects on sinus rhythm are modest, but you can get sinus node depression. And there's certainly contraindications to using the drugs because in terms of some genetic diseases like Brugada syndrome, where the drugs can bring out the Brugada pattern. These drugs are primarily hepatically metabolized, and even with renal dysfunction and creatinine clearances of less than 35, flecainide can be used, but the package insert actually recommends a starting dose of 50 milligrams twice a day at most. So the drugs are well tolerated with few hemodynamic and no organ toxicities.
This was great. What a wonderful deep dive into our Class 1C agents. So just to briefly summarize before we move on, we can consider Class 1C agents for rhythm control and atrial fibrillation either taken continuously if people are having more frequent episodes, or as a pill-in-the-pocket approach to convert infrequent but longer duration episodes. We need to be very careful about their use in patients with coronary disease, specifically if they have active ischemia, not just the presence of plaque or calcium or a history of coronary disease. The functional test looking for active ischemia is the most important thing here, and they are also contraindicated in structural heart disease patients. We also have to remember to always prescribe a beta blocker with them to avoid one-to-one flutter and to look out for other side effects such as sinus node dysfunction. Okay, well, it's a busy day here in the CardioNerds Arrhythmia Clinic, so let's move right along. Natalie, can you tell us about our next patient?
Of course, Colin. Next up, we have Miss Atria, a 65-year-old female with a past medical history of hypertension, diabetes, and a myocardial infarction 6 months ago with revascularization and a left ventricular ejection fraction of 40 to 45%. She is presenting to establish care after hospitalization for a stroke, where she was found to have a new diagnosis of atrial fibrillation. During her hospitalization, she was started on anticoagulation with apixaban. Though she has recovered well, they were concerned about her swallowing function immediately after the stroke and wanted to avoid sedation and a TEE. A CT heart with contrast showed no evidence of a left atrial appendage thrombus, and she was successfully converted to sinus rhythm with ibutatide. Dr. Epstein, this one was new to me. What is ibutatide and how does it work? What class is it and what is the mechanism of action? How could one chemically cardiovert atrial fibrillation using ibutatide, and what adverse effects do we need to know about it?
Again, that's a great question, and I have to say that I am a great fan of ibutatide. You asked 3 questions. The first is, how does it work? It's a class 3 drug and is a potassium channel blocker. That means it prolongs the QT, and there is a risk for torsade-dependent ventricular tachycardia with it that I'll talk about in a moment. The second question was, how does one use it to do chemical cardioversion of AF? And the third was, what are the adverse effects, which I just mentioned? First of all, it's only an IV drug. It should always be given in the context of a monitored setting. A defibrillator should always be present in case torsade occurs. And it is given IV. A second dose can be given if conversion does not occur within 10 minutes. The rhythm should be monitored continually, and certainly if the QT extends dramatically and or PVCs occur, the infusion should be stopped and no more should be given. The conversion rate for new onset AF is at least 60%. For flutter, it's even higher, within minutes to an hour. Patients have to be monitored for 4 hours after the drug is given to make sure that late proarrhythmia does not occur. A trick which has been written about only tangentially is that if a gram or 2 of IV magnesium is given before ibutatide is used, it almost 100% mitigates the risk of torsade. And I must say, in my career, before coming to Penn, I used a lot of this drug, and I saw Torsades only once when magnesium was given prophylactically, and that was on a patient who was on milrinone, and they shouldn't have gotten the drug in the first place because of the severe LV dysfunction. So it's a very effective drug. It needs to be used carefully, and it's really nice because it avoids the need for anesthesia and sedation.
Wow, it really sounds like this is a useful tool for chemical conversion of atrial fibrillation and atrial flutter, particularly if used correctly. I've certainly used it a few times, but it sounds like I should be adopting it maybe even more into my practice. I can imagine many situations where sedation might be pretty tricky. For instance, a MICU patient with tenuous respiratory status, but this may be a really great agent in that situation.
I should also say, as you're talking about its usefulness, it can actually be given in patients who get recurrent atrial fibrillation as well as in patients with WPW. And there were two back-to-back abstracts presented a number of years ago by a fellow who gave these data. The utility of using ibutylide in patients with amiodarone is really very relevant because amiodarone is used so much. And the WPW story is sort of neat because the drug not only converts atrial fibrillation, but it also slows conduction in the accessory pathway. So you don't need to worry about acceleration of the ventricular response as would happen if you gave a beta blocker, digoxin, or verapamil, for example.
That is absolutely very useful data to have. Back to our clinic patient, Miss Atrio was also very impressed with how well the medication worked. She was wondering if there is a similar medication that she can be put on to prevent further episodes of AFib. What options do we have for her, and how would you choose between those?
So ibutylide is a class 3 drug, and in the class 3 group, there is sotalol, dofetilide, and amiodarone. As I said at the beginning of our discussion, I'd really say that amiodarone is a second-line therapy, so our choices are dofetilide or sotalol. In terms of choosing between sotalol and dofetilide, then, if you're avoiding amiodarone, some of it is style. Both drugs are very, very well tolerated, but both of them carry the risk of prolonging the QT and having torsade de pointe. And I should say also that both drugs should be started in the hospital. So let's talk about sotalol first. This is a drug that is a racemic drug that's got both a D and an L isomer. The D isomer is the class 3 portion of the drug, and the L isomer is a beta blocker. The beta blocker effect is quite minimal. It's much less than that of pranolol. And in fact, the beta blocker effect plateaus at 80 milligrams twice a day. So if somebody doesn't respond at 80 twice a day and is still having AF, and you're worried about sinus bradycardia, most of the time you can increase the dose to 120 twice a day, not sacrificing the sinus rate at all, but getting more of a class 3 effect. As I said, the drug is started in the hospital. There's some cardiologists who say that with a normal ventricle, you can start the drug as an outpatient, but I do not subscribe to that because if, God forbid, torsade occurs and the patient expires, that's really on you. And I just don't recommend it. As far as dofetilide goes, it is FDA mandated to start in the hospital. It's a unique drug because the algorithm in the package insert starts the dose high and you decrease the dose if the QT interval prolongs too much. And that is different than virtually all other drugs that we use where we start low and titrate up. It's a very effective drug. And I should say also at this point that all of drugs except amiodarone, if you talk about AF recurrence being 30 seconds, all drugs except amiodarone have a efficacy rate of about 50% of the year. Amiodarone gives you 60%. So for 10%, is it worth it to have that organ toxicity? I don't think so. And then in terms of how do you choose between sotalol and dofetilide? Since both, in my mind, require people to come into the hospital, it's what you feel comfortable with. There's some new information because there is an IV form of sotalol available that rather than having to be in the hospital for 3 days, which is 5 half-lives for either of these drugs, for sotalol, there's an algorithm now that you can give an IV bolus, load the person with sotalol and get them out within 24 hours. And you have to have a unit that where you can observe people continuously when the infusion is given. But it's a nice option if your hospital has that availability.
I can see where that would certainly be more appealing to a lot of patients. Can you go into a little bit more detail about patients with reduced ejection fraction or heart failure and when you would feel comfortable using sotalol or dofetilide for those patients?
Well, sotalol, there's not an absolute contraindication to LV dysfunction to using it. Certainly, the worse the LV, the more reticent I would be to use it. The beauty of dofetilide is that there was a trial called Diamond in which dofetilide was used in patients with LV dysfunction. And there was a dose response beneficial effect in these patients, and it was tolerated very well. So, certainly, if somebody has a poor LV, dofetilide would be the default, and sotalol would be avoided.
Dr. Epstein, can you briefly touch on if there's any differences in creatinine clearance cutoffs for the two medications?
Yeah, actually, in the package in for insert sotalol, there are guidelines for decreasing the dose depending on what the creatinine clearance is. For dofetilide, again, there's guidance that depending on the creatinine clearance, the starting dosage is decreased. If you noticed, I specifically used the term creatinine clearance and not EGFR. All of these approvals were based on creatinine clearance and not EGFR, and we have to, or everyone should calculate the Cockcroft formula creatinine clearance when these drugs are started. I also want to emphasize that looking at the creatinine is not good enough. So for an 80-year-old female, remember there's an adjustment in Cockcroft for female sex. A creatinine clearance of 1.1 in an 80-year-old woman with a body weight of 70 kilograms is in the order of 40 cc's. So be very careful of the creatinine itself. You have to calculate a creatinine clearance.
This is just an absolute treasure trove of information. Sounds like the class 3 agents can be very effective at controlling atrial fibrillation, even in situations where 1C agents are contraindicated. To summarize, in patients with a creatinine clearance greater than 20, it sounds like dofetilide can be a great option, even in patients with a severely reduced left ventricular ejection fraction, while sotalol might not be the best option for patients with significant heart failure and generally requires a slightly higher creatinine clearance of greater than 40. Miss Atria, our patient in clinic, is concerned about medication side effects, though, and remembers the doctors in the hospital talking to her about issues with abnormal heart rhythms with ibutylide. Dr. Epstein, what are some of the adverse effects that we should consider before starting these agents, and is a special protocol required for initiation? What about any drug-drug interactions that we should consider?
For sotalol, there really aren't many drug interactions. I continue beta blockers with sotalol and titrate them down because there is a small beta blocker effect of sotalol. For dofetilide, a number of drugs interact. The ones that are the one that's most commonly that we see is verapamil. There are several others. One thing that's really nice is that most pharmacies now have alerts that if you prescribe a drug and somebody is on a contraindicated one, you will be notified of that interaction.
Well, that is definitely high yield. We always talk about first do no harm, and it sounds like without the proper monitoring, you could definitely cause harm with some of these medications. I know you mentioned a couple things related to how to properly use these and also touched on sort of the slightly newer presented information about whether outpatient loading is possible. And I really think, the safest thing, which you obviously emphasized, is in the hospital, watching them for 5 doses of medication, EKGs after every dose, and really keeping a close eye on that QT and QTC because, most patients tolerate these really well, but you definitely don't want to be in the situation where your patient all of a sudden starts having runs of polymorphic VT and you could have held a dose, et cetera.
Colin, along those lines, I should emphasize also that it's really incumbent upon us to measure the QT ourselves and make the correction for the QTC and not trust the electronic reading from the ECG machine. It can be wrong many, many times. And it's important to not only look at the length of the QT, but also the morphology of the T wave. That when they get real broad and flat, it's a sign that there may be potential toxicity.
Yeah, absolutely. And I know, at least, in my not quite 2 years of being an EP fellow, I've seen patients who start with a normal QT, QTC, and just off of a single dose will develop runs of polymorphic VT. So it's not super common to have that exaggerated of a response, but it's definitely possible. And I've seen it a couple times. So definitely make sure the patients are being monitored on telemetry, et cetera. And Miss Atria, is someone who likes to have, just always wants to have a backup plan. And this is something you already mentioned multiple times. So I just want to go back briefly and touch on this. You talked about using amiodarone as a second line agent, and you touched a little bit on the toxicities and things like that. But I just wanted to sort of do a slightly deeper dive there. Could you tell me a little bit more about if you had a patient who you were unable to achieve control with a 1C agent or a class 3 agent, and you thought amiodarone was the next best option for them? You mentioned chronic efficacy already, but what would acute efficacy look like if they were in atrial fibrillation? Is this something that you should be relying on for cardioversion? Someone might say, well, it works really well chronically. It should put them back into AFib. And then what about situations like heart failure and some of these really sick patients? If you didn't feel comfortable using a medication in severe heart failure, could amiodarone be used there?
Yeah, there's sort of many nuances to your question, and there's several questions. First of all, if for somebody who's stable, how do you start amiodarone if they're already on a 1C or a class 3 drug? And since those latter drugs have relatively short half-lives, you wait 5 half-lives and you can start amiodarone. That being said, amiodarone has this huge volume of distribution. It takes a long time to load. Its efficacy for suppression comes only with when you have about 10 grams on board. So it takes a while to build it up. Who can you start it as an outpatient? Certainly people who are in sinus rhythm, especially if it's, greater than 60 beats per minute. You can just start it and load as an outpatient, whether you use 200 twice a day, 400 twice a day. I wouldn't use 400 4 times a day, which we sometimes do in the hospital, but you can go pretty quick and increase it. For people who are in atrial fibrillation, if the ventricular response is slow, I'm very cautious about starting amiodarone as an outpatient and not cardioverting them, because if they do have spontaneous conversion, they may have sinus node dysfunction and be importantly bradycardic. So an older person with a slow ventricular response in AF, I'd be reluctant to start amio as an outpatient. And finally, the answer to your last question regarding the acute efficacy of amiodarone, certainly PO is not going to work. It's just got too long a half-life, and you have to build up blood levels and tissue levels for it to be effective. In terms of IV efficacy, that is actually controversial in the literature. There are some papers that show that it is equally efficacious to other drugs, and there are some that say that it is not effective at all. Certainly, we see it used in the post-op cardiac surgery patients, not infrequently, but these people tend to stop on their own anyhow. So it's very hard to extend findings from post-cardiac surgery patients to the general population.
So it sounds like amiodarone may be used for outpatient loading in the appropriate patient, acknowledging that the PO formulation may not be as acutely efficacious as other agents we've already discussed. Dr. Epstein, you briefly mentioned some of the adverse effects of amiodarone. Could you go into further depth on those adverse effects that worry you and we should all consider as physicians?
Yeah. First of all, I've mentioned the volume of distribution a couple of times, and some of the physiologic things that happen to patients, which are called, quote, toxicities, actually simply reflect patient compliance. Perfect example of that is corneal deposits, which do not interfere with vision, or the slate blue discoloration of skin. All that means is that the patient is taking the drug and it is not a side effect in the sense that there's something wrong with it. It's expected occurrence with the drug. Pulmonary fibrosis is one of the major risks and important. The main thing that I'll leave as a message here is if somebody's on the drug and they develop a cough, it's on you to determine whether this is pulmonary toxicity or not. A CT scan looking for ground glass appearance is the best way to do that. We used to do bronchs and look for foamy macrophages, but the latter can be present even in somebody who's not pulmonary toxic with the drug. Amiodarone has 2 iodine atoms in its moiety, and it can cause both hypothyroidism in about 5% of patients or hyperthyroidism in 1%. Hypothyroidism is easy to manage just by giving thyroxine. Hyperthyroidism is more difficult. There's 2 types. One is inflammatory, and the other is because of the iodine load, and it's feeding the genesis of thyroxine. The treatment for the former is steroids and the latter, thyroid blockers. We don't do this very much anymore, but somebody who's thyrotoxic and having VT storm, doing an emergency thyroidectomy is sometimes needed. Peripheral neuropathy is seen in some patients. This is very dose sensitive, and sometimes just decreasing by 50 or 100 milligrams a day can help mitigate that. Sinus bradycardia that requires pacing. There's no other way around that. And then the last two real serious things are QT prolongation, which is part and parcel of how the drug works. And Torsade can sometimes be seen, but the drug is not infrequently used in people who have had Torsade on dofetilide or sotalol, and you can get away with it. It's probably because amiodarone's a dirty drug for a dirty problem, and it has class 1, 2, 3, and 4 effects. So some of these mixed effects can mitigate the risk of Torsade. Then finally, we don't have physicians warn patients about this enough. But if a patient on amiodarone has sudden loss of vision, this is not corneal deposits. This is retinitis, and it's a medical emergency, and sudden loss of vision in either one or both eyes and this necessitates an emergency visit to the emergency room. And then to finish this discussion about amiodarone toxicity, what needs to be followed? I think these people need to be assessed at least every 6 months. At a minimum, liver function tests should be obtained, and TSH. LFTs are usually not infrequently increased, the hepatocellular enzymes. We tolerate up to twice the upper limit of normal of those, and that is not a toxicity. It's about part of the drug effects. In terms of the TSH, this often goes up a bit. Any TSH that's less than 10 is usually accepted, but if it gets above 10, thyroid replacement should be undertaken. I also get a chest x-ray on people when I see them, and certainly an electrocardiogram. Pulmonary function tests used to be gotten, but the DLCO, which is followed, is so labile that pulmonary function tests are not part of standard of care anymore. But really, the history for a cough, monitoring the enzymes, thyroid function, and the chest x-ray should be done every 6 months.
And one last question regarding amiodarone. Are there any drug-drug interactions that you particularly look for when you have a patient that is on amiodarone?
Some of them are pharmacologic and not clinically important. Others are clinically important. Interestingly, the two biggest ones used to be warfarin, because amiodarone sensitizes the patients to the warfarin effect and lower doses are required. And the other is digoxin, that it increases DIG levels. But we don't use these drugs so much anymore, so that's not an issue. There are other antibiotics and colchicine and statins, but we don't decrease statin doses, for example, on the drug, even though statin levels can be changed.
Well, it sounds like there's definitely no free lunch when it comes to amiodarone. The increased efficacy and ease of use comes at the cost of significant toxicities and some side effects with long-term use. It can be used safely, as we've all seen, but requires monitoring so we can minimize long-term use as much as possible. Dr. Epstein, what are your thoughts about dronedarone? This absolutely lacks some of the toxicities of amiodarone, but probably at the expense of some efficacy of the medication as well. Do you see this as a viable alternative for treatment of atrial fibrillation?
Yeah, let's start with an aerial view of the drug. First of all, the name sounds like amiodarone, but it is not amiodarone. It's very different in that it has no iodine moieties in it, and therefore it has no effects on the thyroid. Second of all, there's a difference in the sulfhydryl group, which is present, and this changes tissue absorption. So it's got a short half-life, and it doesn't have a large volume of distribution of amiodarone. There are a number of trials that were done that showed some efficacy in atrial fibrillation. It was first approved because it decreased cardiovascular morbidity and hospitalization. But a subsequent trial called PALACE showed that in patients with heart failure, it increased mortality. So it's got imperfect efficacy, and because of the problems with heart failure, it really hasn't been used all that much anymore. In terms of heart failure, it's not a history of any heart failure, and it's not a low ejection fraction. Actually, if somebody has a low ejection fraction but hasn't had clinical heart failure for 6 months, the drug can still be used. So it is definitely a second-line agent now, I think, in the practices that I've seen, but it is a safe drug to use. It does not have organ toxicity.
Okay, guys. Well, the CardioNerds Arrhythmia Clinic is completely booked for the day, so I think it's a good time to get back to another patient. Our next patient is Mrs. Taki. Mrs. Taki is a 68-year-old female with a past medical history of heart failure, reduced ejection fraction, an ejection fraction of 25 to 30%, and long-standing persistent atrial fibrillation. She is currently on metoprolol 100 milligrams BID. However, her ventricular rate has continued to range from 100 to 120 at rest. Her low blood pressure and heart failure have limited her ability to try diltiazem. Dr. Epstein, do we have another agent we can add to better control her heart rate? How does this medication work?
Well, you're now talking about the old friend, digoxin. And on the one hand, dig will slow the ventricular response at rest, but it is not very good slowing the ventricular response during exercise because of the catecholamine effect. The drug works by increasing vagal tone, so sympathetic tone can override that. It inhibits sodium potassium ATPase, so it's helpful in heart failure, and it's a positive inotrope. So it'd be a very nice drug for this person. It may not be perfect, but certainly to slow the resting rate to below 100 is a goal. There have been studies looking at tight rate control versus looser rate control. The looser one is to have a resting rate less than 100, and that does improve outcomes. So digoxin would be a drug to choose. In terms of how much, I know there's a big enthusiasm for drawing levels now, but unfortunately, they're drawn randomly. And all the information that we have about toxicity and mortality with drug levels of above zero point 0.5, for example, come from trough levels. And if we do follow levels with this drug, they should be done right before the daily dose is given. The toxicity discussion about amiodarone is difficult in terms of doses. Certainly, higher doses have more toxicity and risk for mortality. But I'll tell you, in the AFFIRM trial, the atrial fibrillation follow-up investigation of rhythm management, which opened the door to accepting rate control, there are two papers that retrospectively looked at dig levels. One said it was associated with mortality, and another one said that it wasn't. So I think the important thing is to be careful with a drug, use as little as possible. Don't forget, when Withering first used this drug for heart failure, dosing was done by saying, I want you to take 4 digoxin leaves, and if you see colored halos around your eyes or you feel sick, drop down to 3 leaves. So we've come a long way by having levels, but lower doses are better.
So, given its toxicity in this narrow therapeutic window that requires us to closely monitor the concentration levels, when would you advise that we should really be reaching for digoxin?
I think as a second line drug, when a patient just exactly that you described is somebody who is not particularly active, especially if they have heart failure. I just prescribed it this week, actually, a poor gentleman who was a bilateral amputee, and he had rapid ventricular responses. And it's a perfect drug for him because it slows him at rest, and exercise was not an issue. And certainly, if somebody has renal failure, the dose needs to be decreased because there are drug-drug interactions. Any drug that interacts with it and increases level warrants a dose adjustment of digoxin.
Man, this was just a phenomenal day in the CardioNerds Arrhythmia Clinic, and I learned just a massive amount of information. I think a big takeaway for me is that despite sort of the push towards ablation and the general focus on ablation in this day and age, just knowing what percentage of atrial fibrillation patients are still requiring these medications shows you how massive the problem is to control and how difficult it is to control atrial fibrillation. And people really need to know all of the tools that they have at their disposal. So before we finish up another busy day in the CardioNerds Arrhythmia Clinic, Dr. Epstein, could you just tell us what are your main takeaways for the audience in terms of the use of anti-arrhythmic drugs and the different options there?
Sure. Number one, antiarrhythmic drugs are part of your toolbox, and it's not ablation versus drugs. It's how do I use both of them? And one size doesn't fit all. There's some patients who might say, I don't want to take a drug. I'd like an ablation. There are other people who say, I don't want anything stuck into me, and let's start with drugs. I think the second thing is that all of these drugs are poisons with a few beneficial side effects, as my pharmacology professor in medical school said. But if we understand the drugs, we can use them safely. And then last but not least, monitoring is important. And just because the dose is working on one day doesn't mean that it is going to be the appropriate dose the next. And it may require upward titration or downward titration. And we need to see these patients and not give the responsibility to anybody else when we start a drug like this, but we have to follow the patients ourselves.
And finally, Dr. Epstein, what makes your heart flutter about electrophysiology or even atrial fibrillation more specifically?
Oh, gee, I have always loved the electrocardiogram. And I think really getting back to basics is what's fun. There's so much we can learn from the ECG and being bedside clinicians. I have been called a dinosaur talking like this, but I think of myself as an internist first, a cardiologist second, and an electrophysiologist third, because these patients are sicker and sicker now. And we really have to understand medicine to take care of them safely. And I think it's a lot of fun when we take care of patients globally and don't just think of ourselves as an ablationist or something else. So it's a great subspecialty, and I recommend it highly.
Yeah, I just can't agree more. I had the pleasure of being in clinic last week, and I hadn't been in clinic for a while, and it was honestly a lot of fun just to sit and talk to people and have the time to do so. It was really great. And this has just been a phenomenal episode. I've had just as much, if not more fun sitting and talking with you. So I really, really appreciate the time out of your busy day to talk to us about anti-arrhythmic drugs, Dr. Epstein. And thank you so much, Natalie, for putting together this excellent episode, and Kelly for joining us and adding so much wisdom. So thank you, everyone, for a great time in the CardioNerds Arrhythmia Clinic.
Thank you so much for tuning into this CardioNerds episode. The audio editing for this episode was performed by me, Grace Qiu. I'm an intern in the CardioNerds Academy, House Jones, and medical student at Thomas Jefferson University. Check out the episode page for show notes and references. If you found this episode or show informative, please consider subscribing to CardioNerds on your favorite podcast platform and leaving us a review. It really helps us spread the word and further our goal to democratize cardiovascular education. Finally, this podcast is not meant to be used for medical advice. The views expressed on our show and site do not reflect the opinions or policies of our employers. All CardioNerds content is planned, produced, and reviewed solely by CardioNerds. Stay tuned for more engaging conversations and explorations in our new and exciting upcoming episode. And now, my friends, it's time to make like an S2 and split.